Hello to everybody. Welcome to the first stop of Road to Cartagena. My name is Savvas Frangos. I am the current president of the World Federation of Nuclear Medicine and Biology. The Road to Cartagena is in the preparation to go to the World Congress, which will be held in Colombia in February 2026. We organize a series of coordinate conferences, and the topics will be in relation of the objective of the World Congress and will be adjusted in the central theme of each regional meeting. We will cover 88,778 kilometers around the world, starting today from Algeria, and we are going to Singapore, Mexico, Greece, Australia, USA, Spain, Cyprus, and then we landed in Colombia. The virtual stop webinar here in Algeria will be organized together with the African Association of Nuclear Medicine and my colleague Salah-Eddine Bouyoucef. And as I tell you, at the end, we will land it in Cartagena, where Patricia Bernard-Trujillo will expect us for the 40th Congress of World Nuclear Medicine. Today, we have people from Africa to share their knowledge and their perspective about nuclear medicine is Salah-Eddine Bouyoucef, Mike Sathegke, Kgomotso Mokoala, and myself, which will speak about the World Federation. The presentation is this welcome that I have, and Salah will now join us for his welcome message. Mike will speak about advanced target alpha therapy. Then Salah will mention the perspective and future of nuclear medicine in Africa. We will talk about advancing image of gynaecological malignancy from Dr. Kgomotso. And last, I will speak about the global presentation, and then we have the closing remarks. We start today. The red light of Formula 1 is there, and here is a green light to start. Salah.
Thank you. Okay. Thank you, Dr. Savvas, for this excellent presentation about mostly because for us, Africa is going to start with the on the road, this road to Cartagena, and of course there are some synchronous event. We are the three in South Africa because we have just finished the regional training course, and we have been in the facility of nuclear medicine of Pretoria, and with the head of department Mike Sathegke, and his colleague Kgomotso. So I think we are Africa will do the best to make this webinar good and bright. And for that, I will present in few words Mike Sathegke. Mike Sathegke is actually one of the bright leaders in the world about the alpha therapy. And we have seen his facility, preclinical facility. Maybe there are more than 12 or 13 trials on with various radioisotopes. So, Mike, if you hear me, I will give you the floor. Mike will speak about, of course, advance in alpha therapy, nuclear medicine, as mentioned by Dr. Savvas, and I give you the floor, Mike. Okay, you're welcome. Please, Mike.
Thank you so kindly to the President of the World Federation, Salah, the president of African Association, Savvas, and then the president of African Association, Salah, and the president of South African Society, Kgomotso, the 3 presidents, and to the African colleagues, and then of course to Patricia, the president of the Congress that will enjoy next year in Cartagena. This is the road to Cartagena, and the better way, as the presidents have said, is best to start in Africa. And in this way, I'll share my presentation as such, and we take it from there. So as from Africa, we are saying and asking who is speaking the most, and then who is actually going to be the most proponent person to prevail. And we think nuclear medicine will prevail, as one is demonstrating with these 2 pictures. It's a pity we wouldn't be in the same room now, but it's showing which one is female, which one is a male bed. And then, of course, that tells you clearly, indeed, which one it is. But between oncologists, between physicists, between other disciplines, who is who in terms of who will prevail in terms of therapy to cancer patients, in terms of alpha therapies, that lives to be confirmed. But clearly, we know that us as the nuclear physicians are in a good position to guide targeted radionuclide therapy forward, to guide patient cancer care experience to be better. And in that way, we have to say advancement in terms of course, alpha therapy is good. But first, we have to thank the agency for always trying to put across guidelines for us to make sure that whatever we do, the principles and education are firm, and we can also propagate to the governments of the world when we have commissions. And this, I would like the colleagues to really look into these 2 articles that can help guide where we are going and what is happening. I think this is important to note. In that way, it's also to note why is targeted radionuclide therapy growing so much. With the courtesy of Leo Schultz from Novartis, you can see clearly that diagnostic radiopharmaceutical are almost plateauing in blue, but in purple, global nuclear medicine is growing a lot. And that is growing because of the yellow, which is radionuclide therapies. And you can see it is not only in prostate cancer, it is in brain, in breast, lung, neuroendocrine, hematological, and other cancers. That stays true, of course, for both alpha and beta. And you can see why we're speaking about advances in alpha therapies. As you can see, the people, which is a little bit of a focus on my talk, that in all cancers, GI therapy, GU, neuroendocrine, prostate, breast, there is a purple radionuclide therapy happening there, which is a great space for all of us to be excited that we will make a difference in all cancers. And this is exciting. So alpha therapy in itself, why the excitement about it? I have no doubt that all of us in this audience, we know this, but it is indeed a great one because we know that it has got huge linear energy transfer, big energy, the linear energy transfer is great. And then the advantage that it travels a short distance, which means we've got lots of possibilities that we can help ourselves from having side effects such as hematotoxicities. And then which means with the high linear energy transfer, we can have a double strand breakup, which is really independent of the oxygen status. So even in really hypoxic areas, we can really penetrate. But that can only happen when we have proper patient selection, multidisciplinary team, and then of course, also understanding the consequences in our regulators. There are several alpha therapies that are there. Of course, I've already mentioned the advantages thereof, but clearly the ones that are there, terbium-149, astatine 211, course actinium, which I will focus a bit on, together with bismuth, thorium-227, radium, which was the first alpha to be registered, and then of course lead-212. So out of this arsenal of these alphas, the ones that really are making strides is actinium, radium, and then of course I think lead will be number 3 or 2 if you want, then astatine. I think radium will still, radium-223 will come back a bit, especially if it is to be mixed. I'll speak to that. And then why, again, to emphasize, I have said, why the alpha therapies? You can see that alpha therapies, they can break the double strand. They've got a direct effects, but importantly, they've got indirect effects. You can see the bystander effects there, meaning that the neighboring cells will also get angry or they will die because of the effects of radiation that is from the the double-strand break. And then, of course, you've got immune reaction that will lead us to the abscopal effect, which is a very exciting situation in a sense that this means that even if alpha is traveling a short space of time, but its impact is felt elsewhere, distant, and that's making this even more exciting. And then for us to take interest in alpha therapies versus beta therapies, which are traveling a short period of time, is because we want to address the causes of failure for radioligand therapies. We know that beta therapies is great, be it iodine 131, be it lutetium, be it yttrium, they've done great work, but somewhere they cannot go on to have that impact. So when they fail, the big alpha, in our opinion, the alpha, which is really like impacting a bomb within a tumor, then comes in. And of course, that can help with what I've said about those hypoxic areas, and the delivery will be good for micrometastasis as well. But also, when you look at the cell, the replication cell cycle, the stresses responses, it seems like it can bypass some of the mutations that might be found and that might be experienced with beta therapies. And of course, we cannot do without addressing the microtumor environment. So the microtumor environment is a very big cause of radioligand therapy failures. That's why we have the microenvironment excitement, such as FAPI, for instance. But again, alphas can help again and play a space in the addressing hypoxia, vascularization, cancer-associated fibroblast. But what about the alphas general? We have seen in the preclinical facility and preclinical work that there is sometimes not a good correlation between the absorbed dose and what you give. So why is it like that? So it's because the cells of the cancer are not always homogeneous. That heterogeneity is always a problem. So that being the problem, can that also escape alpha? And that seems like that can be the case. So that being the case, then it means, why is it not that the alphas are not succeeding? The bystander effect, the indirect effect that I spoke to earlier, seems like they can help in that regard. And I'm excited about this. This is something that is good, that can actually bypass this, and we must pay attention to this. As we've said, the abscopal and the bystander effect can perhaps help address the non-targeted and targeted effects, but there has to be a balance about this, about the half-lives of each alpha, and then what is the advantage in one ligand versus the other. Those three that I've mentioned, including radium, which is missing here, you can see there is a shortage of supply compared to what we have in a moment. So the supply and demand is a problem about alphas at the moment. We really know that indeed we have a little that we are producing currently in the world, and we need more, because if we are propagating that alphas must have a place in the table, then it means we also have to speak to being there for producing. This just shows again in another way from a good paper by a colleague and friend, Akram, and then that shows from the seminars of nuclear medicine that you can see, we know that we have to image first before we can treat. You know, it must be obviously theranostic, but which of those? You've got the betas and the alphas and the beta alpha that are there, terbium and lead, that is alpha beta, but we've got the alphas that may play a bigger role, and this is the space we'll play in. Of course, terbium might be a bit of a problem in terms of supply, and this one's, hence I've said earlier, that's the space in which we'll speak to, and the space that is exciting in that way. But first, of course, there has to be good imaging and good selection, and we're excited that also with PET, there will be copper and zirconium that will play a role, that you are not only going to image, but you can do dosimetry. That will help you then know to some extent how you can expect the behaviors of those alphas. So this is not to be discussed in detail, but to show the excitement in alphas, that in the prostate cancer space, we've got both small molecule and antibody trials that are happening only on alpha, that is excluding lutetium or excluding any other thing like rhenium, for instance, only on alphas. And this is really a slide that is a little bit outdated already, because there are other alphas that are already there in a form of trials, and that is exciting. But also for neuroendocrine, we know that it's not only Lutathera that is successful. When Lutathera could have a problem, there are some alpha that I will also speak to. Both actinium and lead are leading the way. There are trials that are ongoing there. And then, of course, indeed, there are none other prostate, non-neuroendocrine tumors that are ongoing in pheochromocytoma, melanomas, bladder cancers that we'll still see. And we can see for both small molecules as antibodies, this is the case. So the alphas are really there to stay. I mean, nuclear medicine hasn't made that big impact as yet in breast cancer, which is the #1 cancer for ladies. And I think the alphas address that gap need. Alphas will also play a bigger gap. But with the alphas as well, there is also an issue of what is the best time to actually apply the cancer and the targeted alpha therapy. We know we can see with, for instance, in this example that is from Adrian Merlo for the brain tumors using substance P labeled to actinium, and it can also be labeled to bismuth 213, the daughter of actinium, that indeed it can be a big balance. It can be given before surgery so that it shrinks, and then after surgery, and then of course you can then have a good space to operate, which is an important advantage that we should bear and think about it, including also in prostate cancer. I mean, we are thinking about, there is lutectomy trials that are ongoing in terms of beta emitters lutetium, but the same can occur with the alpha therapies. And remember that the advantage with the alphas is the short traveling point that I've mentioned about the short path, and this is demonstrated as such. And you can see if you give early versus late that the effects are much more different. Now, speaking a little bit about lead, and Dr. Schultz is really a propaganda, together with many other companies that have come up and many other people, I mean, and many people are speaking in this as yet. But he has shown clearly actinium versus lead, the advantages versus disadvantages, that they are all potent, of course, but the half-life of 10 days versus that of half a day, it can be a bit of a problem, and the rapid clearance can be an advantage in this case, in some of the molecules, of course, that can be an argument, and then the toxicities can be low if you've got rapid clearance, of course, that is put as a point, and of course, the supply, it looks like it can be resolved, but again, that leaves to be also desired, because at the moment, it's only the dose that is given, it's not the generator as yet, and we still have the same problem of the supply of both of them. But advantage is that, of course, they are confined and imparting higher energy within the space where they are. And again, like we have seen the other slide with actinium, perhaps more, this time with lead, you can see other trials that are happening with other solid tumors. And this is encouraging only on lead only. And we can see that some are already in phase 3. That is excellent. I mean, we know we've got actinium that is having the lead, the lead as well. It's also playing a role in this case of a neuroendocrine. And this is an example, as you can see, Rodolfo Nunes and their partners that is demonstrated, and Delpa that have shown clearly excellent work. You can see all the lesions that are gone after 4 cycles of lead dotamtate. This is really excellent. And then I think this might also be where, because we've got shortages, you might, for instance, think about having lead tackling neuroendocrine and perhaps actinium going the other way in terms of other solid tumors, such as, for instance, pain. Now, what about radium? Slide from a friend, Elba, that shows very well that radium has done well, but now for it to be repurposed better, it can actually work well in addressing and attacking the osteoclast in the areas that are problematic, but perhaps it can be, of course, by combining it with hormonal therapies such as enzalutamide might do better, with chemotherapy such as the taxanes, and with the PARP inhibitors, I think, and this might be something of importance that can maximize the effect of radium, and therefore for it to come back. Astatine, the advantage is that it has got 7.2 hours half-life, but also the production is not a problem here. And we have seen from the Japanese colleagues that they have done good work in thyroid cancers that are resistant to iodine 131 and in neuroendocrine tumors as well. Perhaps now it can also be fast-tracked in other solid tumors. So the space is exciting. We're showing about radium, we're showing about lead, and now we're showing about astatine that has got a space to play. Now, coming to one of the last ones, we can see that actinium PSMA, we have spoken and presentations have happened, but just perhaps to show this meta-analysis, one of the latest one, which has got a higher number in 1,155 patients, it has been demonstrated that it can have, the overall survival that is great of 82%. I mean, this is great. A PSA deadline of more than 50 that we can experience of 82%. If they have had no therapies, of 72% after the first line of therapy, several therapies, you still have it around 55%, and overall with all various groups around 70%. I mean, this is great point that is actually demonstrated here, and it can only get better, of course. And importantly, we are now seeing in a space of prostate cancer that there can be combination therapies with lutetium, be it with the PARP inhibitors, be it with the immune checkpoints, be it with chemo, and of course, we have seen with the enzalutamide, but it can also happen with actinium, for instance, and perhaps even better in that case. We now have said that we are having a need for other places, such as in breast cancer. So we are involved, fortunately, in Nectin-4 expressing tumors. This can happen for bladder cancers, and it has been proven as a cold drug, and in other cancers, it still has to be shown. But since we can label it, and we are demonstrating that FDG is showing expression of breast cancer in mets, and we have seen this with gallium-labeled nectin molecule from Actis, and this is saying that if you can see it, we can treat it, and clearly then, which implies as triple negative breast cancer can also be addressed with the alphas, and that's an exciting space. In conclusion, Chair, Petra, colleagues, the organizers, and the president of World Federation, African Association, and South African Society, I am saying that really we have a great potential here to address both when lutetium can fail. We have seen with Clemens Kratjoville demonstrating that when betas fail, actinium will succeed. And we have seen in our group and various groups that with doing this type of work, also the hematotoxicities, because these patients are old, but we don't damage the marrow that much. That is the great side of it on the green, and the part that is orangey red that still needs to be resolved. Unfortunately, we don't have the supply. Supply and demand is a problem. We have side effects such as xerostomia, and then we still have to understand the dosimetry and radiobiology, but that is not a deterrent. We've got the good and the unresolved side. We don't say the bad, but it's the side that still has to be resolved. And then, of course, we still have to really go ahead. And indeed, we know that the exercise, we have to really them as it's shown from Judea. And then we really know that the high linear energy transfer is going to speak well to the absorbed doses. We must make sure that the bystander effect don't target the other sides that we don't need to. And of course, this can only get better in a form of a multidisciplinary team. Thank you so kindly.
Thank you very much, Mike. I like to remind all the participants that we have the QA facility. If they would like to ask any of the speakers, they can write their question, and then we will transfer it to the speaker. Mike, you are still there?
Oh, yes, I am, because I'm no longer the focal point. I'm the next presenter to be shown.
Waiting for the QA. I was smiling in the moment that you present this nice picture, and remind me back to 2018, when I was convinced that you are using very good the Photoshop. But indeed, it's real pictures, and this is our efforts and our success as nuclear medicine in this theragnostic procedure.
Well, thanks for that, Savvas, Mr. President. Indeed, I think which is the great work that alphas are doing. Honestly, it's really can only get better. The only problem is that we must sustain it as we really get those images that are the pre and post. They must stay for long. The
future is here. I cannot see any question from the participant, please use it if you want. If not the case, I cannot see any questions. Thank you very much, Mike.
Thank you.
Salah, are you ready to
Yes, I'm ready.
show us
I'm ready, Chair. Yes, I'm
the
ready.
perspective and future of nuclear medicine in Africa? In South Africa, the future is already there. Let's see what about the rest of the continent.
It's showing the South Africa is showing the road. Okay, so first of all, I would like to present myself. I'm Dr. Bouyoucef. I'm a professor in nuclear medicine at the University Hospital of Babelwed and at the Faculty of Medicine. I'm president of the African Association of Nuclear Medicine, and I am going to present something about the development of nuclear medicine in Africa and some future development and perspective. So,
just do slideshow, please.
Okay, you show the slides. Okay, so this one I will.
Salah, please do slideshow.
To slide. Sorry. Okay, we'll stop this one. Excuse me. Like this is okay.
No, you go down.
Sorry, I have this one. Okay, now it's okay.
Okay, now it's super.
Okay. So the development of nuclear medicine in Africa it is associated with a long history to which multidisciplinary involvement from different fields such as physics, physiologists, clinicians have contributed to introduce nuclear techniques in the medical world during the 60s. The maturity of nuclear medicine in Africa was reached in the 90s when several departments of nuclear medicine became independent department in hospitals in Africa. Since nuclear physicians started to be officially recognized as a hospital clinician dealing with medical radioisotopes and commenced to participate to the multidisciplinary medical board. The income in nuclear medicine, where we have 5 countries in Africa of on North Africa and South Africa, belonging to the upper middle income country, have about 85% of the total number of facilities, mostly SPECT gamma camera. And it's the same for SPECT-CT. So the development is now widespreading. More and more SPECT will be installed in several countries due to the increase of awareness and also the important clinical impact of SPECT imaging in major health problems in Africa: cancer, cardiovascular disease, pediatric disease, and so on. About the radiopharmaceuticals, the availability of diagnostic and therapeutic radiopharmaceuticals in Africa is very heterogeneous. Irregular supply of radiopharmaceutical is one of the main factors which limits the speed of development of nuclear medicine, as well as the expansion of clinical nuclear medicine services in many countries. In the continent, South Africa has from a long time its own means of production of radioisotopes and commercialization of radiopharmaceuticals. Egypt more recently started also to assemble molybdenum generator. Therefore, nuclear medicine molecular imaging applications were clearly identified, integrated officially in the nomenclature of biological and medical act, officially in many countries. So during the last 3 decades, Africa has shown a constant development of nuclear medicine and molecular imaging, similar to the rest of developed world in South Africa and North Africa. Meanwhile, in other countries, the growth of nuclear medicine molecular imaging was rather limited to the expansion of basic clinical services provided by study with technetium 1990 and treatment with radioiodine 131. At the end of 2019, data from 45 countries of Africa sharing technical cooperation program with the IAEA showed that 30 countries have at least one unit of nuclear medicine, while 14 others have started feasibility study of implementing their first unit of nuclear medicine and molecular imaging. So what's about the cyclotron and the PET-CT? We have actually 25 cyclotrons in Africa, which are supplying 76 PET-CT machines within the continent. 6 countries located in North Africa, South Africa, Kenya, Mauritius, Nigeria, Tanzania, Ghana are concentrating all operating cyclotron facilities, which most of the time are managed by some private company. Those cyclotron facilities have contributed to a fast development of PET-CT in those countries, particularly in North Africa. We have about 47, South Africa 16. South Africa has one of the biggest public center PET-CT located at Pretoria, where we are now, including hospital, cyclotron, radiopharmacy, preclinical facilities with 3 PET-CT and SPECT-CT and micro-PET as well. So about the PET-CT imaging, FDG is the most common procedures in Africa, above 95%. But we see that PET-CT peptide with PSMA, DOTATOC, are the second performance, particularly in routine in South Africa and North Africa. Modern diagnostic approach also located in South and North Africa, but start to be seen elsewhere, like in Ghana. 2 years ago, they started with the first patient. Prostate cancer is the most common modern therapeutic practice in Africa. So what's about nuclear medicine therapy? We have about 21 countries have nuclear medicine therapy services. However, only 13 countries do have facilities for inpatient. Meanwhile, they treat 2 patients, but there are projects of inpatient. 8 countries, they are able to treat outpatient. They use radioiodine in outpatient in appropriate facility. And this country, North Africa and South Africa, have the densest and the oldest network of radionuclide therapy in Africa, since most of the facility of therapy in Africa with high patient recruitment are concentrated in those countries. So yttrium-90 could be used, and also, like Mike said, we have alpha emitters such like Xofigo and radium-223 and actinium as far therapeutically applied solely in Africa. So what about the qualified nuclear medicine physician? Actually, we have 28 countries who have as far at least one qualified nuclear physician, and 22 have seen their first qualified nuclear physician after the year 2000. Among them, 17 countries after 2005. It means that a big growth recently, and we are actually at the number of 483 nuclear physicians working as a nuclear physician in the country. About radiopharmacists, in the year 2000, South Africa was the solely country with qualified radiopharmacists. Actually, we have 13 countries in Africa to have qualified radiopharmacists or radiochemists. In most of the case, and most of the case, they were trained abroad. South Africa training program in radiopharmacy or radiochemistry already exists at PhD level, and more recently in Africa, some universities have introduced the master of radiopharmacy. Nuclear medicine physicists, medical physicists related to nuclear medicine started in the 80s in Africa, where the first qualified medical physicists have been recruited by hospitals in South Africa, Ghana, and North Africa. After the year 2000, the cooperation of country with EIA has boosted the education and training of medical physicists in several countries, which was successfully achieved a year later. Actually, 18 countries do have qualified medical physicists related to nuclear medicine, and 8 countries have their own system, education system for medical physicists. What's about technologists? Almost 700 technologists work in nuclear medicine in Africa. Many of them have been qualified first as a radiographer and used to work in radiology. 81% of technologists work in North Africa and South Africa. And of course, technologists are in charge of hot lab, operating SPECT, SPECT-CT, and PET-CT. So, speaking about the story of development of nuclear medicine without speaking about EIA, it will be a big mess, because one of the biggest support, maybe the exclusive support of nuclear medicine for development of nuclear medicine in Africa was the EIA. And that here I'm great Diana, has seen the head of division of nuclear medicine with her effort, strong effort in developing nuclear medicine in Africa. And technical cooperation, of course, projects in Africa can be national, regional, or interregional, and to a certain extent, most of the countries they have benefited from the great support of the EIA. The aim of the national projects range from installation, expansion of nuclear medicine services in the country, developing the quality assurance program, implementation of an advanced nuclear medicine imaging like PET-CT, positron emission tomography combined into computer tomography, implementation of advanced radiopharmacy departments started to use the theranostic approach for treating cancer, and other projects. I didn't put them here, and that is the scope in the EIA, which is giving strong support to the development of nuclear medicine in the world, particularly in Africa. So, what are the future and of nuclear medicine in Africa? We expect that the progression of conventional nuclear medicine will be widespread in the continent in the 2D and the 3D mode, as well for the whole body, and heart imaging will be widespread everywhere. Molecular PET-CT and SPECT-CT should be reinforced. We expect that more and more will be installed in the coming years. Functional angiography with Doppler, ultrasonography, MRI, CT, and other new technology in medical imaging will come again, will come also in developing the imaging in Africa. And of course, we think that the promotion and generalization of hybrid imaging will be a reality in the coming years. So the PET-CT is in routine will be the most important objective, because you know, a cancer patient, they need this modality, and FDG modality and other tracer with other tracer. It's very important to have an impact on the cancer treatment. A clinical molecular imaging modality that enable visualization and quantification of biochemical process in vivo. Mike has spoke about it. And PET-CT is improving, of course, the diagnostic accuracy and optimizing patient care. Data from concurrent study are essential for timely diagnosing and management decision in PET-CT hybrid technology. Of course, we expect that we are going to strengthen and generalize conventional radionuclide therapy with radioiodine in Africa. We need to prove clinical utility of imaging and therapeutic agent. That is very important. Now it's possible because we have human resource, qualified human resource, so they will promote and show the importance of nuclear medicine in the continent. The perspective in medium term, we think that the strategy plan of capacity building in nuclear medicine in Africa will continue, and we have some data about 2030 with some standard achievement in terms of health, and nuclear medicine is within those achievements. Expect implementation of nuclear medicine to almost 80% of countries in Africa. Now, mostly we have about radiation oncology is more widespread like nuclear medicine, but nuclear medicine is getting more and more reducing the gap with radiation oncology and medical imaging. Increase the use of PET-CT for cancer patients at least in 50% of counties in Africa. We need more contribution of nuclear medicine in improving the diagnostic effectiveness and prediction of treatment response. That it will be very important. But for our continent, we will show that this nuclear medicine is very important too for cancer management. Better impact of nuclear medicine in improved patient outcomes. That is also one of the perspectives we choose. So what we need more also in perspective, what we are working for to increase the budgets for radiopharmaceutical for the continent. So there will be homogeneity in terms of availability, and we can enlarge clinical application, increase budget of acquiring new equipment, and mostly also new technology equipment, as well as new radiopharmaceutical, and of course reinforce the use of theranostic in prostate cancer and other cancer where when the impact will be shown that it will be real. And the last one, I mean, in terms of real perspective, to develop research center in Africa dedicated to nuclear medicine and molecular imaging, inspired by the South Africa model of Pretoria. Then this could be modeled there, as we have in this event. It was almost more than 41 participants, and they have seen this integrated approach, combining nuclear medicine physician, combining radiopharmacy, combining medical physicists, and all doing a team with special competencies in each field. That it's integrated approach. I think it will be the future of nuclear medicine. It is already in developed country, but for Africa, we have started this story, and I think in few years we are going to see very some success, implementing success, showing success in several countries. And thank you. I have finished. Thank you very much. Before terminating, I would like to thank the chair of the World Federation, Dr. Savvas. I would like also to thank Petra for her great technical assistance, and her passions when communicating with us. I would like also to greet Patricia Bernal, the chair of the Congress, coming Congress in 2026 in Cartagena, Colombia. And of course, I would like to greet again Diana and all EIEA staff for their great support they provided every time for African countries. Thank you, Chef.
Thank you very much, Salah. We have some question. One question is if lutetium PSMA therapy is available in Africa or not yet.
Yes, for this you can lutetium therapy, lutetium PSMA therapy in Africa is existing. Yes, of course, intensively in South Africa, but we have it in North Africa and in some countries, in Ghana, Nigeria. They are going to start. They have heard that they are going to start. Tanzania also, they have a project of starting lutetium PSMA, and there are development. I think it will be it will be, I mean, shared by several countries in the future.
Okay, there are also some questions more personal to you. I think you can answer it in chat. And we are happy that Diana Baez is with us. And thank you for the excellent presentation. I think on behalf of World Federation and Africa, we are deeply thankful to Diana Baez for all her efforts regarding nuclear medicine. Okay. Then you can stop sharing your screen.
It should be done.
And we go forward. A very interesting subject, actually, advancing imaging of gynecological malignancy from our colleague Kgomotso Mokoala, and she is currently the president of the South Africa Society of Nuclear Medicine. Correct if I am wrong.
You're correct.
Please go ahead to enlighten us about the advances in image of gynecological malignancy.
Thank you. Thank you for the introduction and thank you for the invite. As introduced, I'm Kgomotso Mokoala. I'm an associate professor and I'm the head of clinical unit at the Steve Biko Academic Hospital, University of Pretoria and NUMERI. Yes, so the topic has been introduced. That's more or less an outline of what I'll be talking about. Just as an overview, I think we all are aware that in general, malignancies or the incidence of malignancies has gone up, and it's due to several factors, lifestyle, biological, and a whole lot of other epigenetic modifications that occur because of the environment and because of the things that we do, the food that we eat, etc. So if you look at this, these diagrams on the right, you can see that breast cancer is the more common one, but I'm not going to focus on breast cancer. I'm going to stick mainly to the pelvic malignancies, although in some contexts, breast cancer is considered as one of the gynecological malignancies, but for all intents and purposes of this presentation, I'll focus on just the pelvic malignancies. But cervical, and then it's ovarian, and then endometrial is a bit less. In terms of the challenges that we face when we diagnose and treat gynecological malignancies is because patients usually present with non-specific symptoms. In the early stages, before it gets quite big, they may not present or have any symptoms. And usually there is delayed diagnosis. I know in Africa or in low to middle income countries, we have that problem. Although there are programs, especially when it comes to breast and to cervical cancer, there are screening programs that are available. And then with cervical cancer, there's now vaccines that are available. However, we still find that a lot of patients still present with cervical cancer. The incidence is still high in the low and middle income countries, and the patients do present quite late. Again, because of the anatomy and the pelvis, there's room for growth. You find that the diagnosis may be a bit tricky and it may be difficult, and it takes time for eventually the final diagnosis to be made. In terms of the treatment, you have histological variability within the tumors. So sometimes it's not quite easy in terms of the chemotherapeutic drugs that are available. And most of the time, because patients present late, then the surgery becomes a bit more complex, and that is also a challenge. And then options in terms of therapeutic, in terms of chemotherapeutic drugs is also a problem. And then pelvic malignancy, sometimes you have patients with vulvar cancer, and the psychological impact that it has, in the sense that these patients, when women, I guess it's similar to men when it comes to a prostate and the pelvic region. With women as well, the minute people have to lose their uteruses or have to undergo major surgeries for vulvar cancer, it is something that causes a lot of psychological issues, and counseling is an important part of the treatment protocols. In terms of imaging in gynecological malignancies, we play a role from diagnosis all the way to treatment monitoring. And in the early stages, it's mainly ultrasound and CT as well as MRI that are used. However, PET can still be used in terms of staging these patients, so that especially if higher stage from stage 2B is suspected, then you can start incorporating PET. And then in terms of the staging, again, we can assist in terms of looking at the tumor size, the local invasion, lymph node involvement, although again, the more morphological imaging in terms of the MRI is better in the local tumor. For distant or checking how far the tumor spread for distant mets, then you're better with the PET-CT, which does the whole body. And then we also play, again, like I said, a role in treatment planning as well as monitoring response. And I'll go into some of those roles that we played just now. In terms of the traditional imaging techniques, I've sort of highlighted them in the previous slide, but just to sort of say that they all have their advantages and disadvantages. I won't go into, I think we all know them, but we do know that ultrasound is prone to operator dependence, depending on the skill of the user. And it's obviously a local thing, so you're not gonna always pick up everything. CT scanning, again, is usually a limited site, and it's better at picking up local disease. However, it cannot assess the tumor biology. And then when it comes to MRI, we know MRI is very good in terms of pelvic malignancies. However, it cannot, there's limitations in terms of doing the whole body, one, and then secondly, patients may be prone to claustrophobia, and if patients have metal implants, that can also be a problem. I won't go into that because I think I've sort of touched on it in the previous slide. The nuclear medicine imaging techniques that have been investigated, we've got traces. So F18 FDG, which is the more sort of standard of care, currently is, has been used. We've looked at articles, or we've seen articles that have spoken about gallium FAPI and its role or potential role in gynaecological malignancies, and then hypoxia, which is an important component of the tumor microenvironment, and then fluoroestradiol, as well as the other two traces at the bottom there. The role of FDG in gynecological malignancies, according to the guidelines, so the gynecological guidelines as well as the oncologic guidelines, it states that FDG can be used for staging for stage 1B up until stage 4, and then it can also be used for staging, for response assessment, as well as for surveillance. The pitfalls that we all know about FDG, it's non-specific. It can be taken up in inflammatory sites and as well as infective sites. And then you have areas of physiological uptake, especially when we come to the pelvis, where you have, urinary uptake, or in patients that are premenopausal, you may have uterine uptake, which may cause a bit of diagnostic dilemmas in that region. Sorry, I'm not sure why my slide is not advancing. So this is just, in our center, we did a study looking at FDG and its role in patients with cancer of the cervix in terms of the accurate staging, as well as predicting or using the metabolic parameters to predict the outcome of these patients. And it was 126 patients, of which almost more than half of the patients were HIV positive. And in the study, we upstaged 65% or 65 patients, which is quite a large number. And this just, I think, sort of it reiterates the importance of FDG in terms of staging of these patients, because if we were just to use, or they were just to use CT, it would have meant these patients would have probably either been subjected to local therapy, which would have not been the correct treatment for these patients. So again, highlighting the importance of PET-CT and how it can assist in guiding management of these patients. This is just a study that just also shows that we can also use FDG to predict the prognosis. And again, because with the CTs and the MRIs, it's usually localized to a region, and with FDG PET-CT, we've got a total body, so we can then check various lymph nodes, and you can see from these graphs or the charts that you know, in terms of the recurrence-free survival and the disease-specific survival, you can see that patients that had lymph nodes outside of the pelvis, so patients that had no lymph nodes had very good prognosis, and then the minute you start moving to pelvic and then further up into the supraclavicular region, you have a poorer prognosis of those patients. We also looked at patients that had vulvar cancer. So we checked in both staging in the initial staging as well as the recurrent setting, and we found FDG to be a valuable tool in directing the management of patients in terms of the staging patients. And then in terms of restaging, again, we were able to pick up more lesions than if the patients had just gone for CT alone. I'll move on to the importance or the value of hypoxia imaging. So as we know that as tumors become progressively, or as they grow in size, they outgrow their blood supply. And generally in the tumor microenvironment, you find that there are tortuous vessels. The neovasculature that forms is usually quite tortuous, and it's fragile. So these tumors are then prone to hypoxia. And this is just a graph or a diagrammatic representation, just showing the various malignancies, and the blue bars are the normal. So in a normal cervix, this would be where the partial pressures of oxygen are sitting, whereas in patients with the malignancy, then the partial pressures drop quite significantly. And that also is true for vulvar cancer as well, and for breast cancer. So it has been shown that those patients or the tumors that have hypoxia, the patients don't do so well in terms of response to treatment, because we all know, okay, well, we need to know that the oxygen, we require the oxygen effect to have a good response to, specifically, although it's not specific to radiation therapy, but more so to radiation therapy, because we need that oxygen for the fixation of the DNA damage with the free radicals. These are the nuclear medicine traces that have been investigated. There are several SPECT traces. However, I think because of the limitations in terms of already we have an issue with the poor resolution or a poor uptake in terms of the hypoxia traces. So the SPECT traces have been sort of abandoned, and there's been a larger focus on the PET-CT traces. This is just a diagram showing the cell and where the various traces have been investigated that for hypoxia, and how they detect this hypoxic environment, or how they are trapped in the cell and therefore detecting the hypoxic environment. Glucose has also, or FDG has also been looked at as a surrogate marker for hypoxia, because in a hypoxic environment, there is upregulation of the enzyme, and that causes, it also then upregulates glucose transporters, which then are linked to FDG uptake. So the more glucose transporters you have, the more FDG uptake you'll have. However, studies that have investigated the FDG and its role in hypoxia imaging have not really demonstrated it as as a direct or as a good marker of hypoxia. This was a study that looked at gallium nitrometazoles. It was the first study to look at gallium nitrometazoles in patients with cancer of the cervix. And obviously, FDG will have higher SUV maxes and SUV means and tumor to muscle ratios. However, we did find that there was a correlation between the SUV mean and the hypoxia-inducible factor expression on the tumor biopsy that was taken. And this is just an image showing where you have uptake in the tumor, the primary tumor on FDG, and this is where you then had the gallium nitrometazoles study, and you can appreciate that you have some areas of increased uptake. It's not exactly identical to the FDG, and that is also what we found, that you have areas. So it's not always a match where you have FDG and hypoxia. There's always that mismatch. And I think it also then speaks to the reason why FDG cannot be used as a surrogate marker or as a marker of hypoxia, because the two don't always communicate. I think this is just a diagram just showing how hypoxia sort of happens, that the further you move away from the vessel, which is the central, I hope, let me just, sorry, switch on my laser pointer. So the further you move away from the vessel, the more hypoxic the cells become. And I think the importance of hypoxia is that, you know, in terms of radiation therapy, there have been advances that have been made in terms of intensity modulated radiotherapy, where they give a higher boost or a higher radiation dose to the region that is hypoxic in an effort to try and you know, control those cancer cells in that region. And there've also been trials that have looked at hypoxia activated drugs that speak to you know, converting or increasing the oxygen status in those regions, so that then you have a better effect in terms of your radiation therapy as well as your chemotherapy. You know, when looking at the fact that FDG has also been proposed as a surrogate marker, gallium FAPI or FAPI, cancer-associated fibroblasts have been shown to be upregulated by the same hypoxia-inducible factor that is upregulated by, that upregulates the glucose transporters. So we then investigated the use of gallium FAP as an indirect marker of hypoxia, and we correlated the image findings to the staining of the biopsy specimen, and we found that patients with skeletal mets had higher hypoxia-inducible 1-alpha staining, as can be seen there. And I think this was a small sample. However, I think it lays a foundation for further studies and taking in more patients to try and you know, further investigate the value of gallium FAP, perhaps as an indirect marker of hypoxia. Moving on to gallium FAP, again, well, that one was more in the hypoxic setting, but now this is more just pure FAP. We've read of various papers that have come out, I think, ever since there was this big hype about FAPI and its potential to replace FDG and to image various malignancies, including gynaecological malignancies. Various papers have come out, and I think as a consensus, most of them say that FAPI can be used in both staging and restaging. We get very good tumor to background ratios, including cervical cancer. And I think that is an important thing, because you would expect that, because again, in pelvic malignancies, you tend to have urinary activity in that region, so that can mask those lesions. And because with uterine malignancies or with FAPI, there is increased expression of FAP in the normal uterus. So that can sometimes be a limitation. However, various studies have come out to say that that has not been shown to be a significant or cause a significant impact in terms of the reporting. We do have hormonal changes, so there is higher expression or higher uptake in patients that are premenopausal as opposed to those that are postmenopausal. And most of these studies have done correlation with immunohistochemistry and found very good correlation. And with patients with ovarian cancer, we do know that they tend to have a lot of, or they have peritoneal carcinomatosis, and this can be missed in FDG studies. However, because of the low physiological uptake from gallium FAPI, we find that this tracer does performs very well in these lesions. And it's also shown that it can pick up even lesions in the liver, the brain, and GI tract. So essentially, where FDG performs poorly because of physiological uptake, FAPI has performed much better because it doesn't have that problem. This is just an image of one of our patients who's a stage 3C cervical cancer patient, treatment naive, and had both gallium FAP and FDG. And you can appreciate, again, because of the lower liver background, you can appreciate the liver lesions more and the abdominal lesions more. The primary area was similar in both FDG and the gallium FAP. So the advantages of gallium FAP is that it's got, again, like I said, it's got low background and less physiological uptake, and it can still be used in lesions with low metabolism, because we do know that FDG doesn't perform so well in lesions with low metabolism. And so far, I think it doesn't look like it will replace FDG, but I think it has a complementary role to play. And the advantage over FDG is the fact that it can be used for therapy. Again, it's also, you know, after the hype and after everything, the excitement about FAPI, we found that it has uptake in non-specific, in areas of inflammation and fibrosis. And then it's got, you find that there's variable expression within the same tumor and within various tumor types. And also the kinetics and pharmacokinetics in terms of the tracer clearance are still being investigated. And obviously, as opposed to FDG, we still lack some standardization and variability in terms of the uptake. As I highlighted in one of the previous slides, that the advantage over FDG is that FAPI can be used as a theranostic tool. I'll just jump to this slide that just speaks to the various FAPI molecules or FAPI ligands that have been investigated. And, these are the various isotopes that have been labeled to these FAPI ligands to try and investigate which one forms the best pair. Because at the moment, it has been shown that most of the FAPI molecules have a short residence time within the tumors. So we need to look at either increasing or improving the residence time of these FAPI molecules, or on the other hand, pairing it with a good molecule or a molecule, an isotope that has a similar residence time or a similar half-life, so that the two sort of are complementary, as opposed to having a longer-lived, like a lutetium or actinium, a long-lived tracer, radioisotope, and the FAPI residence time is quite short. I won't go much into this, but I think this is an area for development where we need to look at the various things to then decide which patients are we going to select for the FAPI theranostics. But I think for the sake of time, I will just rush through to the next slide. This is a patient that had, unfortunately, there is one paper that looked at, but actually it's all mostly in breast. In terms of the pure pelvic malignancies, I haven't come across a lot of studies that looked at the use of FAPI in those traces, but this was a patient that we personally treated with lutetium FAP46. We can appreciate that this was after the initial cycle, so these were the therapy scans, the anterior and the posterior images, and the patient came around 8 weeks later and was treated, and we can appreciate that the intensity and the number of lesions has gone down, and the patient had reported improved symptoms in terms of bone pain and the ability to mobilize. This is the study that I was talking about that did a larger number of patients, looking at treating these patients. These patients had different malignancies, so there isn't, like I said, one that is specific to gynecological malignancies, but they found mixed results in most patients, and some patients progressed after just one cycle. So again, it perhaps speaks to the fact that the FAP molecule doesn't stay long enough in the tumor to cause the desired effect. and then we need to further investigate perhaps the pairing of the FAB molecule or FAB ligand, again, investigating FAB ligands that have a longer residence time versus the radioisotope. One of the other molecules that has been, or radio traces that have been spoken about a lot, is gallium pentixafor in cervical cancer and or in general in solid tumors. And this is a paper by one of our colleagues that looked at comparing this in patients with cervical cancer with FDG. And obviously, as expected, the FDG uptake was higher. The SUV maxes and SUV means of the FDG were higher. However, they found that in patients that were HIV positive, the expression was higher, or the uptake was higher. And they just, I think in the end, found that there was that complementary role of CXCR4. Again, the advantage of the CXCR4, the pentixafor, to the FDG is the fact that there's a theranostic potential when using the CXCR4. So if you have access to it, I guess it's something that you can consider. This is just a meta-analysis that looked at 7 studies, which had in total 729 patients with ovarian cancer. And they found that the higher the expression of the CXCR4, the poorer the prognosis in terms of progression-free survival and overall survival. And they also found that, the higher the expression together with the poor prognosis was more significant in terms of the correlation in Asian patients as well as in patients with a higher stage of disease, so the more aggressive or the more widespread disease. Lastly, I think I'm going to speak about fluoroestradiol, which, yes, commonly it's in breast, it's more investigated in breast cancer patients. However, in patients with uterine cancer, you do find, or in general in the uterus, you have estrogen receptors. So it has been looked at as a potential for imaging as well as for possible, for imaging for now, sorry, just for diagnostic purposes. So this is just a diagrammatic, a picture showing the FDG versus the fluoroestradiol, and you can appreciate that the uptake is quite, widespread, and on the FDG it was underestimated. And we hope that this phase 2 trial will get the results as soon as it's done in terms of the recruitment and the outcomes. This study looked at patients with essentially pelvic issues, but mainly uterine. So they looked at, and then they tried to see the fluoroestradiol or the FES uptake in the differences in terms of if there was a hyperplasia, carcinoma, sarcoma, or leiomyoma. And what they found is that which is strange, but perhaps so the fluoroestradiol uptake was higher in patients with hyperplasia than FDG, whereas in carcinoma, the reverse was true. And with the sarcomas, they found that there wasn't much of a difference. The significance in the there was no significant difference between the two in terms of the uptake. And in leiomyosarcoma, again, there was not much. They found that the FES uptake was higher than the FDG. I think generally for all gynecological malignancies, the challenges that we need to consider is tumor heterogeneity, the retention, so optimizing the radionuclide selection, drug delivery strategies in terms of the therapeutic aspects, and then the clinical translation. And I think for now, like I said, there's FDG that is available as a standard of care. However, we then need to look at how do the others fit in the bigger scheme of things and what role they have to play. And that also comes with getting them approved by regulatory bodies and then checking that we are not imposing a higher radiation burden to these patients. Lastly, I think just to sort of highlight the fact that with the advances in artificial intelligence and the improvements in the technological equipment that we use, there is a value in using artificial intelligence and as well as radiomics to predict patient response to treatment and to just assess the aggressiveness of these tumors. Obviously, in terms of the general challenges that, in terms of gynecological malignancies or these newer traces, is the fact that certain traces are not widely available. I spoke about the standardization of reporting as well as the imaging protocols that would make for, and when we compare studies, it would make it a bit more easier to have more robust data on all these various traces if we're having the same, or we're speaking of the same language and saying the same thing. And then the cost and the access to nuclear medicine services, and again, need for future, like more prospective studies and clinical validation of these newer agents. Looking into the future, we need to explore new traces. Some of the traces that I've mentioned, I think we just need to expand and to do more, like I said, prospective trials, and to expand on the theranostic applications. I think I speak mainly for low-income countries where you still have a large volume of patients presenting with cervical cancer or these gynecological malignancies, and they're presenting quite late with limited options. So if we can figure out good molecules or good radioisotopes that can assist in terms of the theranostic component, that would be a plus. And then obviously use the use of AI for image interpretation and for predicting and prognosticating these patients. Yeah, I think I've sort of covered everything. So in conclusion, again, we need to standardize, we need to look at therapeutic molecules, and we need to do large prospective trials. Thank you.
Thank you very much. I think it's a future there, and we are more experienced how to apply nowadays the theragnostic part of nuclear medicine. There is a lot that we need to learn about gynecological cancer, and nuclear medicine is a new subject for us. But I am optimistic that in the near future, we will have good results also for this patient. I don't have any questions. If anybody like to type a question, please do it now. Okay. Thank you very much. In that case, I will conclude with my presentation. I will try to talk about the World Federation. Once again, my name is Savvas Frangos. I am currently the president of the World Federation of Nuclear Medicine, which was founded in 1917 at the Third Alaspin Congress in Mexico. And then we have the first World Congress in Nuclear Medicine in 1974 in Tokyo and Kyoto. The World Congress came back to Japan in 2022 as the 13th World Congress. In the last 55 years, the World Federation has served as the global linking of nuclear medicine worldwide. And as we mentioned, that's why we are doing also this road to Cartagena. We are going in Colombia 2026 for the 40th World Congress. Here are our member states. And as you can see, Africa, we have only few countries there. I think increasing nuclear medicine in countries in Africa will be also for benefit for the countries if they join the World Federation and have linking to other society. There is a major change in the structure of the World Federation. Till 2018, we have the World Congress every 4 years, and the President, Secretary General, and Treasurer of the Congress were at the same time President of the World Federation. In 1st of January 2019, the President, President-elect, Secretary General, and Treasurer were elected by the member states, and I had the honor to be elected as the first Treasurer under the new format and serve in this position from 2019 to 2021. The World Federation of Nuclear Medicine, except the President, President-elect, past President, Secretary General, and Treasurer, we have in the Executive Board also other society, including the African Association of Nuclear Medicine. Very important in the collaboration, and I will come back to this, is the International Atomic Energy Agency and the World Health Organization. Here is the new leadership starting 1st January of 2025. Myself as President, Gopinath Gnanasakara as President-elect, he is in UK, John Prior as Treasurer from Switzerland, Gisela Estrada as General Secretary from Mexico, and Lisette Lu, who was the President till 31st of December 2024, is now immediately past President. This is the core leadership, and we make the decision and lighting where the World Federation will go. Important connection is, as I mentioned before, with Diana Baez from the International Atomic Energy Agency, and World Federation is a non-state actor in the World Health Organization and is the only representative of nuclear medicine within this United Nations organization. And John Prior, except to be our treasurer, is also our contact or focal point for the World Federation. What is our primary strategies? To offer educational resource online, also to organize webinar like the one that we have right now, work with the SNMMI, AANM, International Atomic Energy Agency for distribution of relevant educational material, provide educational material for developing countries, free copy of journals or primarily via the internet, encourage companies to support establishment of permanent QA labs for teaching, form partnerships with existing entities to develop educational resources that don't duplicate, and we don't duplicate what already exists, and we disseminated also established guidelines. What were our activities? We work together, as mentioned before, with AANM, SNMMI, and International Atomic Energy Agency to develop webinar in their native language for low-income society, including subtext translation in pre-recorded webinar. This is a job to be done. We have also a practical arrangement with the International Atomic Energy Agency, and is all this what I mentioned before, that is our cooperation between the World Federation and the International Atomic Energy Agency, especially in the person of Diana Baez. And it's expected that this practical arrangement will be renewed by the end of this month. We already apply our wish to extend the practical arrangement. We participate in the Lancet Oncology Commission. Diana Baez and Andrew Scott, who is represent the World Federation, and this Lancet Oncology has established the impact of access and availability of nuclear medicine on improved patient outcome and return on investment, justifies support and funding from government for workforce, equipment, radionuclide, radiopharmaceutical supply, and image study. That means this Lancet Oncology Forum prove that using nuclear medicine is not only for the benefit of the patient, which is obvious, but is also a good investment from the medical health system. And is also developing a global perspective on access and availability of theragnostic and identified mechanisms to improve patient access and funding for this important new area of cancer therapy. And is a recent publication in September 2024 that this Lancet Oncology Commission is talking about radiotherapy and theranostic. And in the acknowledgement is also the acknowledgement for World Federation of Nuclear Medicine and Biology, who invest not only with person, but also with money. In the World Health Organization, we like to strengthening the diagnostic capacity for non-in vitro type. And we are also in progress for a new WHA resolution on strengthening image capacity. This is based on the Lancet Oncology Commission on Medical Image and Nuclear Medicine, but is very important because if we are successful, and we are thinking that we will be successful, this will also share with all the countries and to apply this resolution. We also participate 2023 for the safety of the patient, myself 2023, and Lisetta Low in 2024. And we also participate in IPED 2024 with our president at that time. We make also a change in our logo. We wanted to modernize the logo, and here is the new logo, which is also very the World Federation of Nuclear Medicine and Biology is written very we will have also, we publish a book to be also ready in the World Congress in Cartagena 2026. And the name is Journey of WFNMB and its member countries. I advise you that you send to copy the history of your own country to be part of this book. About the site of World Congress 2030, that is the next Congress after Columbia, no society has expressed interest. And one of the reasons is that the time is far away, let's put it like that. And we are also plan to do it in-house. And if they are interested, the member society can assist us to take over for the 2030 World Congress. We speak about the road to Cartagena. We are traveling around all the continents. And we start today. We are going to Singapore, Mexico, Greece, Australia, USA, Spain, Cyprus, and then we landed in the Cartagena. And here is a short film that Patricia and Patricia Bernal-Trujillo will be there to welcome us. And I was once in Cartagena. It's a very lovely place. And I'm sure under the guidance of Patricia, we will have an excellent World Congress. Just notice your calendar for February 2026. If you like to know more about the World Federation, you can read my recent published editorial in the European Journal of Nuclear Medicine and Molecular Imaging. If your country like to have a membership application, just contact our office and they are more than welcome to assist you into this. Let us create bridges that last over the year, like this Chelefos Bridge in Cyprus, which was built between 1489 and 1571. Thank you very much. Okay. If is any question, any comment, I cannot see any in the QA. I think we are reaching the end of this first stop and the webinar, and I will give the word to Salah for his final remarks to close this webinar.
Okay, thank you, Chair. The webinar was really very successful, and we have had some intervention and some clarification from you, and the excellent presentation from Mike and Dr. Kgomotso. And of course, Africa is part of this World Federation. Will go along with you. 2026 Congress in Cartagena with Patricia Bernal as a chair, and I hope all of you good. I mean, I hope that we are going to see you in the Congress. All of you will be in the Congress because we need to see each other and exchange our experience, professional experience, and discussing about development of nuclear medicine. And my last words is that thank you, Chair, for this excellent webinar, well conducted, well prepared by Petra, and with two bright lecturers giving an excellent conference, up to date. And I wish you excellent weekend, and thank you very much. And the webinar is closed. Thank you.
Thank you very much to all the participants, to Mike, to Salah and Kgomotso for their excellent presentation. Thank you very much once again.
Thank you. Bye.